Hello, everyone. Thank you for joining. My name is Francisco Barrio, and I'm a graduate of McGill Desautel. I live in Mexico City, and I'm a former investment banker and private equity associate. Now I'm the founder of a small coffee retail concept, Cafetero. Currently, I'm involved with the McGill Alumni Association and volunteer as a global ambassador for Mexico. I decided to volunteer because my years at McGill were amongst my most formative and exciting. My undergraduate experience completely changed my outlook on the world. And when I moved back to Mexico City after graduating, the absence of an alumni chapter left a big hole in my life. I craved the diversity and the intellectual stimulation that life at McGill offered. So in 2017, I decided to start organizing events to bring the alumni community in Mexico together. My, Myself and my fellow McGill Alumni Association global ambassadors in Latin America have decided to join forces and put together this webinar to engage the McGill alumni community in our regions. The global ambassadors that created this great event include Rosemary Engels, LLB in 1983 from Costa Rica, co-chair of Republica Media Group; Carolina Bocanegra, BCom 2010 from Colombia, specialist in finance, planning, and performance management at Equion Energia Limited; Leo Sano, Bachelor of Arts 2002 from Brazil, Director of Business and Finance at Pan American School of Porto Alegre; and lastly, Juan Agustín Argibay Molina, LLM 2014 from Argentina, prosecretario letrado PGN en Procuraduría de Criminalidad Económica y Lavado de Activos. Juan will be moderating a question and answer period with our speakers after their presentations. Global ambassadors and branch associations exist in many regions around the world. We're a group of proud McGill alumni whose goal is to connect alumni with each other and with the university through meaningful engagement opportunities in our region, like this webcast today. We plan to continue to host a variety of events and get-togethers, hopefully in person in the near future. Now, as for the format of our webinar, in a few moments, each of our guest speakers will give a brief presentation on their current COVID-related research projects. Following the presentations, there will be a time set aside for question and answers, moderated by alum Juan Argibay. Please feel free to submit any questions you may have for the speakers in the question box and address them to Davina. We will do our best to answer as many questions as possible. This brings me to the introductions of today's speakers, Drs. Jonathan Kimmelman and Zeev Rosberger. Dr. Kimmelman is James McGill Professor of Biomedical Ethics at McGill University and directs the Biomedical Ethics Unit, as well as his own research group, STREAM, Studies in Translation, Ethics, and Medicine. His research centers on ethical, policy, and scientific dimensions of clinical development. He has sat on various advisory bodies in the US, NHLBI, and the National Institute of Allergy and Infectious Diseases, served for 4 tours of duty on US National Academies of Medicine committees, and chaired the International Society of Stem Cell Research on guidelines for stem cell research and clinical translation, the Revision Task Force in 2015-2016. He's also deputy editor at Clinical Trials and serves as an associate editor at PLOS Biology. Dr. Zeev Rosberger is a McGill graduate. He's currently an associate professor in oncology, psychiatry, and psychology at McGill University, and was the former chief of the psychology department at the Jewish General Hospital. His clinical interests include psychosocial oncology, quality of life and coping, psychotherapy, cognitive behavior therapy, and distress. His current research includes cancer-related infertility, psychosocial issues in HPV screening, testing, and the HPV vaccine, quality of life, sexuality, and satisfaction with robotic surgery in gyn-oncology patients, screening for distress in cancer care, and fear of recurrence. More recently, he's studying how to enhance COVID-19 vaccination intentions by eliciting pro-social altruistic motives. So with that, welcome again to all, and I'll turn it over to Dr. Jonathan Kimmelman for his presentation.
Great, thank you so much. Thanks for the invitation. I'm really thrilled to be here. Let me just get this thing set up. Okay, good. I assume everyone can see that okay. So I will get started. So as the introduction said, I am a bioethicist. I spend most of my time trying to think about sort of how we can apply systematic ethical thinking to the kinds of challenges that physicians and or medical researchers encounter in their day-to-day work. And among some of the really vexing challenges here that often physicians encounter is conducting clinical trials. In a clinical trial, you're doing a scientific experiment. So in a sense, you're using patients as research reagents, but at the same time, as a physician, you are obligated to provide care for those patients in the same way that you would provide care outside of a clinical trial. And so there's any number of different challenges that we encounter when we conduct clinical research and trying to maximize the welfare of our patients, but also maximize the quality of the knowledge we generate when we do that research. Now, my research focuses primarily on the ethics of clinical trials. And in doing this kind of work, you often uncover a lot of ways that the research system works really, really well, and other ways that the research system doesn't work so well. Some of the ways that research produces findings that sometimes actually mislead medicine. And so in early 2020, when reports were beginning to emerge about the outbreak of COVID, and this seemed like this was going to crystallize into a full-blown global pandemic, having studied clinical research and again, some of the ways it works and some of the ways it doesn't always work, I was primed to identify a number of issues that were likely, in my view at the time, to emerge as challenges to the way we generated good information and knowledge about how to manage the COVID-19 pandemic. Now, what was distinct as pandemic was gathering speed was that there were many apologists, both in the medical literature as well as in the mainstream press, that were arguing that because of the urgency of the pandemic, that we could sort of relax some of the ethical standards and some of the scientific standards, and that we could sort of suspend the normal rules of doing research, a position that I characterized as pandemic research exceptionalism. And a premise of this pandemic research exceptionalism is that it's better to do not perfect research, to do flawed research now than to have no evidence at all. And basically what I want to leave you with, at least one thought that I want to leave you with, is that actually sometimes a little bit of information is worse than no information at all. That's a common dynamic that we have in medicine. And so as the pandemic unfolded and we saw the research response, there were a number of different dynamics that quickly emerged in the way that researchers were pursuing trying to develop treatments for COVID-19. One of them was that there were a number of trials that were initiated that used really problematic designs that were likely to not really give us a reliable result about how to manage or cure or treat COVID-19. A good example of this is one of the first studies to report the promise of using hydroxychloroquine for the treatment of COVID. This came out of Didier Raoult, a researcher in France. And this study, if you looked at it really carefully, although there was a lot of buzz generated from this, it was a tiny study, only 20 patients. Normally, you would need hundreds of patients to really nail down whether something is effective. It didn't use randomized design. It was open label, so there was no blinding. So really not the kind of study you would ever want to really base policy on. And yet, this actually got quite a bit of uptake in the mainstream press and to some extent in the medical literature. Another example were some of the early reports of using remdesivir to treat patients with severe COVID-19. Here you have a case where the most prestigious medical journal out there, New England Journal of Medicine, is publishing basically what amounts to a case series in their purporting to show that remdesivir is effective against COVID-19. Case series are a very poor way of measuring whether a drug is actually effective. And actually publishing this case series was more or less inconsistent with New England Journal of Medicine's policies. And yet, again, because we had such urgent conditions, many people viewed it as okay to publish results that were likely to be highly unreliable. So there's really sort of two problems with reporting, weak results in research, particularly in a pandemic. The first is that you report weak studies. Weak studies tend to be biased towards detecting effect of a drug. And so if you have these early results that are reported and they're likely to be biased, you have excess use of a treatment early on in the pandemic. And that's especially problematic when you have healthcare systems that are really pressed for resources. You have those limited resources being diverted towards treatments that are ultimately ineffective. But there's another concern that I highlighted, which was that oftentimes when you disseminate treatments on the basis of weak evidence, patients and physicians develop really strong preferences for those treatments, such that they're much less likely or willing to enroll in a placebo-controlled trial. And as a result, it's really hard to run those rigorous, large clinical trials to decisively determine whether a treatment is actually effective. So you end up actually setting back the progress of trying to figure out whether treatments are effective. So another dynamic that we saw emerging early on in the pandemic was that there were a lot of trials that were designed without very much forethought about the feasibility. And a good example of this, again, is hydroxychloroquine. About 175 clinical trials that were launched by July of 2020. Most of these studies never ended up recruiting their entire sample. They really were just too small to really kind of decisively answer a research question. And in fact, some of the really well-designed studies had to close because they simply couldn't recruit enough patients because they were competing with other trials for those same patients. So again, here we have a dynamic where there's sort of two sort of ethical problems. Number one, these weak studies mean that you're enrolling patients in studies that can't actually decisively answer their scientific questions. So their burden actually of those patients goes unredeemed by advancing medicine. But the other issue here is that a lot of small studies, again, they not only are likely to produce inaccurate and biased findings, but because they're competing for a small group of patients with COVID-19 at the time, they're pulling patients away from really well-designed, rigorous studies that are going to give us decisive answers. So it hasn't been all bad news. I would say that by the time we were at June or July, a lot of the really exciting, modern, well-conceived clinical trials had really gotten their legs and were beginning to produce some really exciting results about how to treat COVID. So in addition to there being a lot of really poorly conceived and designed clinical research, there are a number of examples that I want to highlight of some really inspiring and impressive research that gives us a picture as to how we might make advances against cancer and other kinds of diseases in the future. So recovery was a good example. The UK really led the way in terms of implementing really innovative and impactful studies. This was a trial that has enrolled almost 40,000 patients. It was testing multiple treatments side by side with each other, in addition to having a placebo comparator. And it was adaptive. It could add an arm if there was a promising intervention, and it could drop an arm if an intervention looked like it wasn't that promising. And it was really this study that provided the first evidence of a real sort of game changer treatment for managing COVID-19. That was dexamethasone. But also it was the first or one of the early studies to show pretty decisive evidence against using hydroxychloroquine in convalescent plasma, although there was a big Brazilian study as well. And it was also one of the earliest studies to demonstrate the promise of using tocilizumab in patients with severe COVID-19. So I want to close with a couple remarks. I think that in many ways, we can view COVID, the way the research community responded to COVID, as a prism for some of the strengths and weaknesses of the way we do research under non-pandemic times. And if there's any hope of a silver lining in the research response, it's that we can sort of derive lessons from some of the weaknesses in the way that we responded to the COVID, and also derive lessons from the strengths of the response. So I want to go through five sort of key lessons that at least I've taken away. The first is that I think we actually need more research and better designed research for testing non-medical interventions. So I think COVID made clear that we're pretty good at designing really, really good clinical trials that can give us decisive answers about vaccines, about monoclonal antibodies, and about some of the other treatments that I've mentioned. So that worked pretty well at the end of the day. Unfortunately, there are a number of other public health interventions or social interventions for which the research community did not really respond effectively. The pandemic, as sort of winds down in sort of high-income countries at least, we really haven't moved the needle much in terms of understanding what kind of mask wearing actually improves outcomes, what kinds of social distancing policies reduce infection rates. We haven't learned much about school openings and closings. We haven't really used the pandemic as an occasion to learn about how to better communicate with the public using rigorous research methodologies. So if there's any, one big lesson is that we're really bad at testing interventions that are non-pharmaceutical interventions, and I'd like to see improvement on that front. The second thing is, I think that it's clear that we need less research, but the research that we do ought to be much better designed, coordinated, and reported. Again, a number of examples of really sort of small, uninformative bias studies that actually set us on the wrong direction early on in the pandemic. Third, I think the COVID pandemic has really shown us the power of coordination. The recovery trial that I mentioned, that UK model, was really well coordinated with the National Health Service in the United Kingdom, such that about 15% of patients in the UK were actually recruited into those clinical trials. So really, really impressive coordination between the research system and the healthcare system. And if we can sort of design that coordination system, sort of get it nailed down, we can really make a lot of progress quickly about a number of other diseases potentially. A fourth big lesson is the importance of rigorously evaluating interventions before you actually implement them. In this case, you had a number of interventions that looked a little promising based on small, probably biased clinical trials. A good example of this is convalescent plasma, that were quickly taken up into clinical practice before they were rigorously evaluated into clinical trials. But ultimately, clinical trials showed many of these interventions to be ineffective, and that means we ended up wasting a lot of time and a lot of resources, and in this case, actually a lot of patient blood on ineffective interventions. And the last point that I want to reinforce, and I think is particularly relevant for a community that is largely in South America, is the vast inequities in the way that we do research. And I'll just close with this one thought. Here in Canada, we are, upwards to 60% first vaccinations. That's great. It's really exciting. But if you look at the different countries under which the vaccines that were approved in North America, where these were tested, they were primarily tested in US and Canada, but also in places like Mexico, Brazil, Peru, Argentina, Turkey, countries that have had major challenges with COVID. But those vaccines have not really been rapidly made available in those same countries that for which they've been tested. And that's a dynamic that recurs in medical research. A lot of the interventions that we enjoy in countries like the United States and Canada were at least partly tested in countries that are middle-income countries or even low-income countries. And often it takes years before those interventions are actually made available in those places. And so I think what COVID has sort of made clear, it's a reminder about some of the inequities in the way that we develop these interventions and distribute the fruits of that development. So I'll close there. Thank you.
Thank you very much, Dr. Kimmelman, for that enlightening presentation about how the response of the clinical research community to the COVID-19 pandemic exposed some of the strengths and weaknesses of current clinical research enterprise. Before transitioning to our next speaker, Dr. Zeev Rosberger, I want to remind you all to please feel free to submit any questions you may have for the speakers in the question box, and you can direct them to Davina. Now, I would like to welcome Dr. Zeev Rosberger, who will speak to us about COVID-19 vaccine hesitancy.
So thank you very much for inviting me. You can all see the screen, I hope. Is that right? Yes?
Yes.
No?
Yes, we
Anybody?
see it. We see
Okay,
it just
good.
fine.
Thank you. All right. I just wanted to make sure. So I'm going to be talking about vaccine hesitancy, some of the research that I've been doing over the last 10 or 15 years. But in general, talking more about vaccine hesitancy in general and how we can translate some of the issues into what we're going through right now through this pandemic. I just added this slide about 5 minutes before the talk because I saw this online. Those of you who may be aware that this Judge Benitez just overturned the ban on assault weapons in California, but one of his reasons in his decision was in fact that, and this is a quote, more people have died from the COVID-19 vaccine than mass shootings in California. This is patently untrue. And I'm going to talk a little bit about how untruths and have affected, and misinformation have affected our attitudes towards vaccines in general for quite a long time, and how it's affected us today. So, as you can see from this cartoon from the 1800s, when the cowpox was given to individuals with smallpox and seemed to have an effect, there was actually an anti-vaccine society. So vaccine hesitancy is definitely not a modern phenomenon. It goes back a couple of hundred years, and it continues to sort of rear itself as new vaccines come to the fore. In the last, in 2019, as the WHO decided on their 10-year plan and their focus on certain diseases worldwide, one of the threats that they focused on and have made a priority is, in fact, vaccine hesitancy, because vaccine hesitancy is not a uniquely Western phenomenon. It actually is quite prevalent in low and middle income countries, even when vaccines are available. So vaccine hesitancy is defined as delaying acceptance or refusal of vaccination despite its availability of services. One of the major problems, of course, as Jonathan has alluded to, is access. And access in low and middle income countries is always a major challenge. And the definition here is not that vaccine hesitancy is a yes/no phenomenon, but in fact is really a continuum. There are many people who accept all vaccines for themselves, for their children, some who will accept some and delay, some will refuse some but are unsure, and then there are the quote-unquote anti-vaxxers who will refuse all. Heidi Larson, who wrote just prior to the beginning of the pandemic, really anticipating what we're going through now, is that even after the worst flu pandemic we had 100 years ago, the rapid spread of misinformation and undermining trust is really a challenge. And this was before the pandemic, so she was quite prescient. And one of the issues is that we must dispel vaccine hesitancy by building trust. And I'm going to come back to that theme and avoiding the term anti-vaxxer because it's quite provocative. So more recently, there's been an assault on vaccines because of the purported relationship between the MMR, the measles, mumps, rubella vaccine, by Andrew Wakefield, a physician in England, who published a paper in Lancet, which is here above, which ultimately was found to be bogus and based on false information and conflicts of interest. And in fact, if you look it up now, it's still there on the web, but there's a big red retraction. And the CDC in the States, and it's well known through multiple studies, vaccines do not cause autism. Nevertheless, there are many people who continue to believe this, and I'm going to show you some interesting data that I've come across recently. So this is a way of looking at vaccine hesitancy. And what's interesting in this theoretical model is that as confidence in the abscissa goes up, that the competence or how much you know about vaccines tends to be very high. The less people know, the more confident they tend to be. As you get to know more about the vaccine, you realize that it's very complicated. It's hard to understand. It might make sense, but at the end of the day, it's actually very complicated. And vaccine hesitancy is a very complex issue. And this is supported by this study that showed that in a large survey, that those who are low in autism knowledge, actual factual knowledge, and tend to be more overconfident in their understanding of it, but those who are high tend to be less confident. And those who have autism misperceptions have the opposite kind of view. It's counterintuitive, but in actual fact, it makes a lot of sense based on the model I just showed you. In this same study, 36% of respondents thought that they knew as much or more than doctors and scientists about the causes of autism. And overconfidence is, as I said, highest with those with low levels of knowledge about the causes of autism than those with high levels of misinformation endorsement. So overconfidence is also, in the last point, associated, what's interesting, with increased support for the role of non-experts. So you're more likely, if you are overconfident in your understanding of what vaccines do or don't do, you might be more likely to listen to non-scientific sources of information. A recent analysis of COVID-19 related tweets, about 4,000 of them that were done here in Canada, had these 5 specific themes: concerns over safety, but also suspicion about political or economic forces that drive the COVID-19 pandemic or the vaccine development. So really this kind of mistrust in government, mistrust in pharma, showed a lack of knowledge of vaccine, confusing messages, and certainly the opportunity to study communication patterns. Just this week here in Quebec, the communication about the second dose has been very confusing. And a lack of legal liability from vaccine companies. These seem to be the tweets. We know that misinformation on social media spreads faster than factually correct information. Even with a little bit of factual information, misinformation really results in long-term attitudinal behavioral shifts. It really is a Pandora's box. Once it's out of the box, it's very hard to stuff it back in. And in addition, this misinformation is even shown to lead to information avoidance. So that if you pick up on misinformation, it seems to have a certain salience that limits your capacity to really look for more information and process this information in a more constructive manner. So the kinds of work that I've done over the last 15 years, not so much clinical, but more public health, epidemiological, has been looking at the HPV vaccine in particular, and decision-making around the HPV vaccine by parents for their young children in our school-based programs here in Canada. And one of the things that we did was that we developed 2 scales and published them. On the left, a vaccine conspiracy belief scale and a vaccine hesitancy scale based on some items that were developed by the World Health Organization, a working group on hesitancy. The vaccine hesitancy scale was published a couple of years ago, or 3 years ago, and now has been used quite widely around the world. There are differences between HPV, which is a sexually transmitted infection and the cause of cervical and other HPV-related cancers. So it's quite different from pandemic, where we have urgency and acute infection and morbidity and mortality. However, the same kinds of issues come up with vaccine hesitancy for the HPV vaccine. It is given to children primarily before sexual debut, which seems to have the biggest impact. These are just some items from the scale, so that you can have a sense of the kinds of questions. Yes, it's a brief scale, and it's a highly valid and reliable scale that we've been using in our research and with colleagues around the world. And in spite of the fact that in Canada, we have a public free school-based programs in every single province and territory, if you look at the most recent data from 2017 in terms of uptake of the HPV vaccine, there is still hesitancy. In the East, not too bad, really in the 70s, 80s, and 90%. In Quebec as well, upwards of 79%. But as you go out west, hesitancy seems to be even greater. And it seems as though the social, political kind of differences between the East and the West, at least in my estimation, seem to have an impact. In Alberta, the Catholic Archdiocese actually banned the schools, the Catholic school system, from giving out the vaccine when it was initiated. After much lobbying by colleagues across the country, that was changed, and where there was 11% uptake for girls at the beginning, it went up to 70%. So there was really no reason to block the kids from getting the vaccine. So it's slightly different. So what influences changes in decision stage over time? We did several large surveys of parents of HPV vaccine eligible children, 11, 12, school age, grade 4, grade 5. And we asked a number of questions. We asked parents where they were in their thinking. Did they know, what did they know about the vaccine? Were they intending to get the vaccine, etc.? And we found some very interesting, and we did the survey over two surveys over with the same cohort over a 9-month with no intervention, but a 9-month interval. And we found there were two types: flexible hesitant, people who were still thinking about it, concerned about it, but the factors that seemed to have the greatest influence were social, friends, family, and so forth, physician, healthcare professional, always comes out as one of the most important factors in influencing vaccine uptake, increasing vaccine knowledge, higher family income, white ethnicity, which means that people of color in lower income families, marginalized communities, as we've seen in the States with the COVID vaccine and even in Canada, tend to have less access and to be less likely to be uptake of the vaccine. And there's a small number, what we've called the rigid hesitant, who stayed mostly unchanged. They didn't change their status over the 9 months, about 8%. And most studies are very clear. Between 8 and 10% are what we would call anti-vaxxer, rigidly anti-vaccine. The good news is that there are some well-studied, well-resourced, scientifically based, evidence-based strategies. This came out not long ago, earlier this year, by Lewandowski and others. It's available at this website. It's a PDF that's downloadable, and it provides a number of strategies as to how to deal with people who are hesitant. You don't challenge them. It's a conversation on an individual level. I'm not going to go into the details. We can discuss it. But basically, it's about active listening in a non-judgmental way, talking about the pros and cons, and trying to build trust. Trust is extremely important in eliciting positive responses. So just to bring this up to speed, and with my current research program, so I'm showing you this as of May 29th, just a few days ago. You can see our uptake has been really high for the first dose in the older age groups, as it should be. As younger groups have been brought on to the scheduling, clearly there's room. But we expect in the 18 to 39 age range, surveys have shown that this group is less likely to get vaccinated because they feel less vulnerable. And in fact, there's very little morbidity, but there is morbidity and very little mortality, almost none. And the 0 to 9, 0 to 12, there's virtually no mortality. So they're less likely to seek vaccination. So what we're doing is, as was mentioned by Mr. Molina, is that we are just now about to launch this project where we've developed a brief video that focuses only on pro-social and altruistic motives. It's a cartoon-like 2-minute video that we've worked on with a local media company. It's almost ready. We're just finalizing it, and we finalized our survey. We're going to do a randomized trial and giving it to 18 to 39-year-olds across the country to see if we can influence those who are not yet ready to get vaccinated or who profess to be hesitant, and see if we can influence them by doing for others, even if they're not interested in doing for themselves. We're also waiting to hear from CIHR about a larger study to examine some of these same issues, in addition to the behavioral issues that Jonathan alluded to. So these are my knowledge of my team. This is a complex area with a lot of interesting work to do, and I'll stop there.
Thanks both professors for their great presentations. At this point, let's open it up to any questions or comments that you may have. And you can use the question feature on your screen to type the question, and we will address it. The first question, it says, in Latin American countries, there is an ongoing debate about the tension between healthcare and the economy. Specifically, which group of population should be prioritized during the vaccination campaign, the active or the risk factor?
So I assume this question is directed to me because I'm the ethicist. Let me start by just saying that, like every scholar, I tend to sort of focus my expertise in a particular area. This is not, I don't work quite in that area, so I'm stepping outside my sort of, real expertise. But generally, I think the way most ethicists would see this is that, all people have identical moral status. A highly economic, productive individual has the same sort of rights and the same moral status as, someone that lays on the couch all day and doesn't really do anything. And generally, you would want to assign healthcare resources to people that have the greatest needs, people who are most at risk for losing years of life and for having disability and whatnot. So for those reasons, generally you would want to assign resources to groups that are the most vulnerable. You would want to, people who have pre-existing conditions, people who are aged, et cetera. One of the reasons why you would worry about assigning to the most productive members is that some of the reason why those individuals are productive are the results of inequalities that are, that are unfair. Some of us, may have all sorts of opportunities to be economically productive that other people don't. And so if you were to assign healthcare resources to people who are the most, productive economically, you would really be recapitulating, if not even amplifying, those unjust inequalities.
Excellent. The second question says, I would be curious as to Dr. Kimmelman's opinion on how the recent deviation on COVID-19 clinical research might affect the traditional clinical research enterprise. Are there any side effects that might perpetuate or become part of traditional clinical research?
Yeah, I have the same question. So I have a couple sort of impressions that I think will change a little bit. Preprints, for example, were sort of on the sidelines. There were, before the pandemic, there were some small community of true believers who were advocating using preprints. But I think increasingly this has become really kind of a central part of the information economy of medicine. So people publishing the results in a non-peer-reviewed setting so that they're disseminated and then publishing them in journals later. So that's going to really change, and that's going to change the way that information gets to the public because, preprints, journalists and other people can access those preprints. So you'll find out about a lot of findings earlier, but some of those findings are going to be spurious and they won't be peer-reviewed. So that's one change. I think telemedicine, a lot of trials were conducted, during the pandemic. We still were conducting cancer trials and, trials against MS and all sorts of other diseases. But because of the pandemic, many of these trials were conducted in, various ways that are different than normally the way we would do them. A lot of more remote medicine, data collection remotely and whatnot. And I think it's likely that you'll see more uptake of these kinds of remote approaches to collecting information on patients. And I would say the third thing, I could talk all day. I don't want to monopolize. I'll just say the big other third change is that I mentioned that recovery trial, which is what's called a platform study. So it's basically, it's like a machine that you plug in different drugs and you turn the crank and it's going to put out results over time. Before the pandemic, platform trials were basically only being used in cancer, and there was some discussion about bringing them into other areas. They're very complicated to run, but I think post-pandemic, you're likely to see more of those kinds of platform studies go forward. So I think there's some real positive developments that we will have learned, but of course, there's some negative ones as well that I could talk about later. But I want to make sure we get to other questions.
Excellent, thank you. Dr. Rosberger, a lot of trials evaluating media campaigns or other public health level interventions have short follow-up periods or only evaluate changes in knowledge or attitudes. Will the planned trial evaluation, the 2-minute video, evaluate long-term behavioral outcomes?
Well, we're going to be, that's a very good question, and it's a critical question because certainly there are not a lot of long-term studies, and they're difficult studies to do for sure. In this particular study, it really is a pilot. It's really a kind of high risk, high reward opportunity where we are working very hard to have a kind of a video that really is purely, if we can say that, focusing on doing for others and not the personal benefits of the vaccine. It's a tricky thing. We're doing some focus groups as we're developing the video. So in this particular study, it's being funded by McGill, the immunology, the MI4 program. It is a short-term follow-up. We will be following these people up for 3 months and see what whether there are changes in intentions. It's pre-post. So half the people will get the video, half the people we randomize to just a public health information a package, and we'll follow for 3 months. If we get some good results, I think we could expand from a theoretical basis, maybe expand it into something bigger, more long-term, but it's really a pilot at this point.
I think that we have time for one more question or comment. Give me just a second. Here. I have friends from Africa who are hesitant to get the vaccine due to the controversial use of Africans as test subjects or for such things in the past, and the sense of distrust. Have you seen this in your statistics, or is it co-funded by access to POC?
Do you want to answer that, or should I, Jonathan?
Well, it sounds like there's parts that you can answer and parts that I can. So why don't you start?
Well, I think that's true, and there's a long history, particularly in the United States, of for example, the Tuskegee experiments of doing these very unethical trials with minority groups and hard to reach groups who don't have power, and so there is that kind of suspiciousness. It exists in Canada amongst our First Nations as well, because they've gone through this as well. And so it's a major challenge. So it's very important, I think, to target messaging specifically for those groups. And that's why I don't work with those groups. There is an institute, CIHR Institute of Aboriginal Research, and they have the connections, the methodology, the relationships with the communities that are absolutely critical for this kind of research to be done. And to improve uptake of any kind of intervention, including vaccines. So there's a long history there, and it's a justified history, and I'm sure Dr. Kimmelman can expand on it, the ethics of it.
Yeah, no, I'll just say really quickly. I mean, I agree with everything Dr. Rosberger said, and I'm just going to, amplify something Dr. Rosberger said earlier, which is the importance of trust. It's really crucial that we organize and implement research in a way that engenders confidence, not just to the people who are using the information, physicians and whatnot, but the people whose bodies we need in order to generate this evidence. You need patients who feel like they're, going to be taken care of when they go into trials. And you need people to feel that those trials are generating information that's relevant for them, that they're in the service of them. And that's really, why, a lot of what I think about in my work, when we think about how to design clinical trials, how to orchestrate a drug development program, it's not just about protecting the individual subject, it's about conducting the research in a way that is likely to engender the confidence of the people that we need to go into the studies, but also the people who are going to be using the information. And I think historically we've done a terrible job at that. I think there are ways in which we've made, some advances, but I still think that we're under-delivering. And I think a good example of the way that we're under-delivering is that if we continue to inequitably distribute the benefits of research, people who are most in need of the fruits of research are going to, with some justification, regard that research enterprise as not really responding to their needs. And so I think that's part of the equation in fostering an equitable research enterprise.
Well, thank you very much. I think that's just about all the time that we have today. I want to once again thank Dr. Kimmelman and Dr. Rosberg for being part of this event. Most of all, thank to all of you for joining today. And let me conclude with a few plugs. First of all, do not forget that you can read hundreds of Made by McGill stories from your fellow McGill graduates at madebyMcGill.ca. And I encourage you to share your own story through the link on the site. I haven't already bookmarked that the McGill alumni website, and alumnimcgill.ca. I highly recommend that you do. It is the best way to keep up to date and on all our McGill Alumni Association initiatives and news, including events, career resources, volunteer opportunities, alumni honors and awards, and homecoming. Thanks again to all of you for joining us today, and I hope you enjoyed the event. Thank you very much.